Hey, everybody, welcome to the podcast. Today, we have another great guest on the show. This is Dr. Devika Bhushan. We'll get into a little bit of our funny connection from 15 years ago that we didn't even know that we had until recently. So I'll give her introduction, a little bio, and then we'll jump into the episode. Dr. Devika Bhushan is a pediatrician and public health leader on a mission to drive health innovation, promote equity, destigmatize mental illness, and spread tools for resilience. As California's acting Surgeon General 2022, Dr. Bhushan was a key advisor to the California governor and led policy and practice innovation at a statewide level by co-leading the launch of the ACEs Aware initiative. Her expertise spans trauma-informed systems, stress and resilience, mental health, and gender and health equity, with work published in The Lancet, Pediatrics, NPR, and the Los Angeles Times. Dr. Bhushan trained at Harvard and Johns Hopkins and serves as senior advisor to entities that aim to advance health, innovation, and equity. She also leads a well-being community to spread evidence-based tools for resilience through a newsletter, YouTube channel, and podcast called Spread the Light with Dr. Devika B. Dr. Bhushan is an immigrant, a parent, and a first-generation Indian American. So stay tuned for this one. This was a quality episode talking about bipolar disorder and being an advocate for it and being quote-unquote out or self-disclosure as a physician with bipolar disorder. All right, enjoy. All right, everybody, welcome back to the show. We've got somebody I'm very excited to be talking with, Dr. Devika Bhushan. So we have a fun connection we'll get into in just a little bit, but I'll let you introduce yourself first, and then we'll go from there.
Sure. So my name is Dr. Devika Bhushan. As you mentioned, I'm a pediatrician, a public health practitioner, and I also live with bipolar disorder. So I'm sure we're going to get into all aspects of those identities in just a minute. It's great to be here.
Oh, it's my honor to have you on the guest. So that's cool. It was funny because I reached out initially because I was like, oh, you're doing some advocacy and this is awesome. And I like always having docs with like lived experience and following them along. And then I saw that we have a connection from way back in my like pre-doctor life. And I think we just saw your husband was actually somebody
on
camera. I knew him from like 14 years ago. This goes into the whole like thing that Salman knows everybody, every brown person in the world, which is, we're reinforcing stereotypes that all the brown people know each other, but we actually do. So, and that was going to be my first surprise question, right? So you just saw that we had met 15 years ago. What social media site did your husband convince me to join back then?
Must have been Facebook.
No, it was Twitter. The hellscape that is Twitter now.
He was an early adopter of basically anything that is technological. Yep. And, so that doesn't surprise me at all. He actually also convinced me to have a Twitter account way back when it first, was possible. And I didn't use Twitter for probably a decade after opening that account. How about you? When did you get active?
So very similarly, like I had like that initial kind of burst with your husband, and then some of the other people were like, "Oh, this is kind of cool, a new social network thing. This will be fun." And then it kind of were like, "All right, whatever." It just kind of died down a little bit. And then I think in the past couple of years, I kind of restarted to use it, and I was like, "Oh, this is actually like something that could be useful." And then Elon bought it and has destroyed it.
Right.
But it's got its pros and cons, and always depends on how you use it, right? So
that's true.
Yeah.
But that is really wild. So you probably met Ashish around the same time I did, right? Were you 08 as well?
08, yeah. So 08, okay. I think I was saying like 08's when I left America to go to the Cayman Islands to go to med school. And
right.
it was that summer before, is like that when we kind of hung out and stuff.
Got it. Yeah. Okay. So 15 years ago. And it's wild because, thinking back, Ashish and I met in 2004, right after we got to college, probably the second week there.
Yeah.
So that was 19 years ago.
Oh,
right? And we actually didn't start dating right away. We had a complicated sort of coming together story. Started dating in 2006, which now was 17 years ago. I mean, these are These are people that we've known for the majority of our adult existences. It's pretty cool.
Yeah, no, I was like coming right up to this. I was like, when I was thinking about it, I was like, oh my God, that was 15 years ago. And I was like,
Right.
I like still remember like we had a great time that weekend and it was a good time. It was a good time. So,
I
oh
love
man.
that.
Yeah. So
It's a great connection.
small world, but
Small world.
we make it
But we're
work.
meeting here for the first time, which is
Yeah. Which is
really,
great.
really great as well.
Yeah. So that's awesome. So, all right. So the reason we brought you on, right, for amongst the personal connection, right, is that like kind of like what you described. You said you're somebody who lives with bipolar disorder, and you've become very outspoken about it, or at least kind of opened, or at least self-disclosed about it. And I wanted to kind of talk about that because I think it's something that people don't talk about is physicians, docs with bipolar disorder, people in general with bipolar disorder don't always talk about it. So let's start with there. What was kind of your personal experience, your kind of bipolar journey per se?
Yeah. So, in a nutshell, my bipolar journey was that I had depression as a medical student with no prior symptoms of hypomania, mania, depression in the past. So I was 23. I had a really pretty rough summer where I was away from all of my contacts and supports. I was going through a series of really trying circumstances,
Hmm.
and just started feeling like I had never felt before, very out of body, couldn't sleep, didn't really know what to say or do, and just feeling very out of sorts. And I thought, it's going to normalize when I get back home, and it didn't. It got worse. And so I went to see a psychiatrist at the urging of my family members who recognized that this potentially was clinical depression, even when I hadn't. Because in my mind, I thought that I had to feel very sad, and I didn't feel any sense of sadness. I just felt vacant and
Yeah.
completely, out of control. And so, diagnosed with depression, started on routine antidepressant with an SSRI, which ended up triggering what, in retrospect, was clear hypomania
Hmm.
layered on top of the depression, which was interpreted at the time to be depression plus anxiety, right? And
Yeah.
over the course of about 3 years, I was trialed on 20 different antidepressants, many
Oh
of
my
which
goodness.
were activating, many of which essentially didn't really work to address the core symptoms, made me, cycle in and out of hypomania plus depression, a mixed state.
Yeah.
And essentially, at the end of those 2.5, 3 years, I was on three different activating meds at the exact same time. And those triggered a manic episode. And it
Hmm.
was such a blessing that I had that manic episode because all of a sudden it was very clear that my symptoms were on the bipolar spectrum. I would respond better to mood stabilizing medications than to antidepressants. And finally, I had my first hope in almost 3 years of seeing myself back again, getting
Yeah.
my brain back, being
Yeah.
able to finally do schoolwork. In medical school, which, I'd started to feel like this is never going to happen for me. I might as well just drop out. This whole career path is not meant to be. And to finally sort of reclaim who I was on a personal side, too. We spoke about my husband at the outset of this, and things were very rocky between us when we were still trying to figure out what was going on for me mental health wise. And I was symptomatic. And, getting well was such a blessing in so many ways, but we were able to finally come to a place where he and I were solid, and we got married at the end of medical school, like a year
Nice.
after I got to a good place from a medical standpoint. And then thereafter, I was sort of, naively entering residency, thinking I've got my regimen. I figured out what my diagnosis needs to be. I've got my, non-medication strategies for staying well, and I can take anything. So I
Yeah.
entered pediatric residency, actually pediatric neurology residency at
Nice.
Johns
Okay.
Hopkins, thinking, all right, bring it on. The same schedule that everybody else has in place. Let me just try on and see if I can do it. And so, I I had a couple of mood episodes in the context of day-night switches, 28-hour calls, which in retrospect, we know that people with mood disorders and bipolar disorder specifically are very, very sensitive to circadian rhythm shifts. Not that
Right.
28-hour calls are healthy
For
or good
anybody.
for anybody,
Yeah.
and that's something that I feel strongly we should be looking to undo, in the medical training system that we have in the US. But
Yep.
for me specifically, like, those were the triggers for really severe mood episodes that required me to take overall 5 months away, and to transition away from the pediatric neurology program that was, set up for me into a general peds residency, because I recognized that I could only do residency, on a very slightly abbreviated schedule in terms of not doing those 28-hour calls and not doing the
Right.
day night flips. And the pediatric neurology portion couldn't accommodate, having one of three residents not be able to hold pager at night, which was fair
Yeah.
enough at the time.
Yeah. Yeah.
So anyway, I graduated from pediatrics residency, and 2015 was actually my final episode, ever since coming into a place in my life where, professionally, I can have more control over my days and my nights and sort of the overall volume of work. Subsequently, I was in academic pediatrics and then transitioned into public health and policy work, working at the state level in California at the Office of the California Surgeon General. And all of those kinds of settings were ones where I could thrive and not worry about circadian rhythm shifts, and have been able to stay well through sort of intense professional, um, you know, requirements and moments, but also through my first pregnancy and postpartum period, which happened 2 years ago.
Okay.
But
Nice.
I'll
Yeah.
pause there, and that's sort of my snapshot of my bipolar journey.
It's a lot, right?
Yeah.
Because I think you're coming from this from like a very unique perspective in regards to as a medical student, right? And we learn this stuff, right? Not we learn like we do your rotation on psychiatry and you're like, oh, bipolar disorder, and we need to learn this stuff for the tests and the exams. Again, like people who may not know, like all medical students have to take the same board exam, the same kind of general knowledge, baseline knowledge is there. So we rotate on stuff. We all have that exposure to stuff. And then kind of seeing it within yourself, kind of, what do you think were some of the things that maybe were harder to see amongst yourself versus some of the patients that you may have come across during your training?
Yeah, I mean, I think that honestly, the only symptom that I was having difficulty kind of equating to the learnings that we had was really my first episode
Yeah.
of depression. But thereafter, like anytime I had any kind of mood fluctuations, I would usually be the first person to kind of tune in and understand and notice what was going
Yeah.
on, with the help of sort of therapy and family support and all of those kinds of things. But I will say, like, it was a really tough experience to go through as a medical student, to become a patient in a very stigmatized context. And
Yeah.
um, in training, both in medical school and in residency, I remember very damning statements from colleagues made towards patients of ours who had bipolar disorder, right? I
Oh,
remember, for
absolutely. Yeah.
instance, like, you know, coming in to get sign out on an overnight set of events. And this patient had been admitted to our service for a non-psychiatric reason, but also had bipolar disorder. And there had been an altercation overnight between, the 17-year-old and her roommate. And the way it was signed out to us was essentially, well, you can't believe what this patient said of the story because she has bipolar disorder.
Ah.
And these sorts of statements of both sort of otherizing and marginalizing people with bipolar disorder,
Yeah.
and the fact that, like, this us versus them mentality, that like no one within our inner circle could possibly carry that same diagnosis, because it then carries with it all of these labels and stereotypes and judgments and assumptions about what kind of person you must be.
Right.
I think those sorts of implied judgments really made it difficult for me to share my diagnosis with most of my colleagues through my
Yeah.
training.
Yeah.
And it made me feel probably more self-stigma and shame around the diagnosis, because you internalize a lot of these assumptions that are out there in the world that you hear verbalized
Yeah.
around you. And you feel less than. You feel like your symptoms and your episodes and your illness is something to be ashamed about. And it took me a long time to undo a lot of those assumptions and learnings.
Yeah. It's really tough because we hear all this stigma towards the patients throughout all of medicine, right? Throughout all of like the training, even for like when I was going into psychiatry itself. Like I vividly remember, like we're doing a surgical case. I was with and the attending is just like, bullshitting with me, the stupid med student. And it's like, oh, what are you going into? I was like, I'm planning to go into psychiatry. And he's like, why are you wasting your career? Why are you
Mm,
wasting your training doing this stuff? And
mhm.
then like, even, I say my wife is a nurse. She did a lot of stuff with like trauma patients, ortho patients, and now she does like more neuro stuff. But like there'll be times where I'll overhear like her kind of talks and stuff, and they'll say things like, oh, the crazy jumpers, they broke their legs again. And like, the stuff that's like, that's not a cool thing to kind of say about your patients who obviously are going through something and they've had an attempt and they've jumped and broken their legs. You can't just be like the crazy jumpers, right? That's not okay to say.
Right. Yeah, we really vilify and make fun of our patients. And I mean,
Hmm.
even terms like chief complaint, right?
Yeah.
Like we are, so for those who don't know, when we write our notes,
Yeah.
the thing that the patient is coming into you to get help with is labeled their complaint, right?
Like
So
chief
there's
complaint.
somebody who's just, it might be something very serious, but,
Yeah.
it's labeled complaint. And we often call patients poor historians, difficult, dramatic. Like there's all of
Yeah.
these ways in which we um, cast judgment on their experiences and um, create this very like judgmental us versus them mentality where they're caricatures and we get to laugh at them behind closed doors, and it's horrible.
It is, and it's one of like the good things in a way that I like about the whole switch there was like to the open notes. I think it was about a
Yes.
year ago. So now patients have access to their notes. They can look and see what kind of terrible things that we're writing about them.
Right.
Um, and the reality is that like, and I think we were leading up to that. There was always like, using patient-centered language and
Hmm.
not using stigmatized language for, I mean, obvious reasons, but
Yeah.
now especially for the fact that everything is wide open now. So it's good. It's good to make those changes, right? We have to progress and change the field. So good.
It's slow in coming, but it's super, super necessary.
It's
Actually, my colleagues and I at Stanford, when I was there in 2018 and 2019, we worked on a write-up, but also a workshop for, medical professionals to really understand the ways in which we stigmatize patients using the
yeah,
language that we do. And so both written language as well as verbal language, which is sometimes where it shows up even more when we're doing
yeah,
these, informal sign outs and, transitioning care from one team of doctors to another, and created really a toolkit for folks to be able to check themselves. And,
yeah,
we're in these very busy clinical contexts where we do rely more on heuristics, and biases show up, in times where we're really stressed and busy and we don't have time to think,
yeah,
broadly and be curious. But what are some of the very quick and easy ways you can sort of check yourself and help to destigmatize the language that's there about a patient? Because it does influence not only how we perceive patients, but the care that we provide. So there's
yeah.
really good data to show that, for instance, in sickle cell crises,
Oh yeah,
when we use stigmatizing and patient judgy types of language in the clinical record, we tend to discount pain that is real, and we tend to treat it less
yeah.
aggressively by as much as 25%.
Yeah, and in a kind of a self story, a shame on me when I was younger, kind of things. Like I remember, hearing again when I was rotating through the emergency room. I think for a lot of people don't understand also when we're psych residents as interns, we rotate through the emergency room as well. And I remember taking care of a sickle cell patient, and they're like, "Oh, I'm 10 out of 10 pain,"
Hmm.
and I was like, "Well, you're eating Doritos right now. How can you be in 10 out of 10 pain, right?" And like looking back now, I'm like, oh my God, how terrible and judgmental was I to even think that like just because they're eating a bag of chips right now, like they can't be in pain. Like,
Mm.
and I got reamed out and and yelled at for it, but rightfully so. But it is that aspect where exactly what you're saying is we have these biases that come through and show up, unfortunately. So
Hey, all of us have biases, and for you to be able to recognize and, relive that moment
yeah,
publicly and talk through, the fact that you feel like you're maybe incorrect in that moment is huge. A lot of
yeah.
people can't do that.
I think we all have like our moments in time, right? And the training where we mess up and stuff. So it's all good. Coming back a little bit, I know you talked about your initial journey being like you said 20 medications over 3 years.
Yeah. Yeah.
Oh, right. I'm in my head. I'm like groaning because one of the things I preach over and over again is like, if the treatments that you're trying are not working, something's wrong with the problem, right? That meaning the problem is not right. Your target is
Right.
wrong of what you're trying to get.
Right.
Talk about that because I know, and then I think tying into that also like the idea of like hypomania versus mania. Because again, like I'm a child psychiatrist, so I don't most of my time is child psychiatry, and hypomania and mania is one of those hard things for people to kind of differentiate all the time, right?
Yes.
Yeah. If you want to go into that a little bit.
Yeah, absolutely. So I was diagnosed eventually with bipolar disorder NOS, which meant
Hmm.
not otherwise specified. We weren't sure where on the bipolar spectrum I would end up. Um, and in the end, got the diagnosis of bipolar 2 disorder, where most of my episodes are depressive. So like 70 to 80% of the time, that's what I show up with. And then 20 to 25% of the time, maybe I'll have a mixed quality to it, meaning I'll have a little bit of hypomania layered on top of that. But just to step back and sort of, tell people what that means. So mania is fairly obvious when it happens.
Yeah.
Mania is this big flight in terms of sort of where you are in energetically, right? So you might be up for days, you will have racing thoughts. Sometimes you'll go into sort of a break with reality. So you might have psychotic thoughts where maybe you think that the TV is speaking to you. It's giving you a certain kind of message. Maybe you're the Messiah, right? And it's your job to save all of humankind from something that's coming. You might have grandiosity is the word we use for it, where you just believe that you are invincible, you're amazing, you are this, you are God's gift to the human race. And oftentimes, hypomania is much more subtle. So it's a little bit of an elevation. So you might have quicker thoughts, you might be interrupting people, but it can be harder to diagnose because it can present like anxiety. Or like irritability. And it doesn't necessarily have to be, positive in terms of the way in which it is experienced. So, for instance,
Yeah.
for me, most of my hypomanic periods, since I was put on mood stabilizers have been dysthymic, right? So I don't enjoy being hypomanic and
Yeah.
as much as I don't enjoy being depressed, right? And I think actually that's been part of why it's been easy for me to sort of stay on course in terms of the treatment plans.
Yeah.
But for me, dysthymic sort of hypomania has felt like just this like feeling of being on edge and revved up, but not being in control of my mind, right? So I
Yeah.
might start to read something and just not be able to make sense of it because my mind's flitting from place to place. I might really want to sit down and do something productive, but not be able to really have the focus to sustain more than 15, 20 minutes of work on that thing.
Yeah.
Not be able to sleep well. Be very, very short tempered with the people I love and care about, and really feel like I don't have much of a control over that. So you can see how, that kind of thing, when somebody doesn't sleep for a few days and doesn't have bipolar disorder, they might have similar symptoms. And so it is much more of an art to diagnose hypomania, especially for the first time in somebody who doesn't have a family history of bipolar disorder and doesn't have their own known history of hypomania or mania, right? And to make
Yeah.
that diagnosis for the first time when you're, in that context of a medical student comes into you depressed and you give them antidepressants that seem just not to work, it's a hard call to make. But one other thing I'll just kind of share with the viewers or listeners is it's not for nothing that on average it takes 11 years to diagnose bipolar 2 disorder from the
Yeah.
first symptoms to the point at which it's very obvious what the diagnosis is. And that is because hypomania is as potentially subtle as it was in my case. And I was lucky, right? Like 3 years is much less than the average of 11 years. And actually, I'm
Yeah.
working on a film called Brainstorm to really
Okay.
help educate people, including in the primary care workforce, around how you recognize early onset bipolar disorder, symptoms of hypomania, to really try to prevent this 11-year tragedy that
Yeah.
most people have to live through.
I think you're right, is that it can be very subtle, right? The hypomania aspect of things, almost to the point where I know there's like schools of camps of thought that are like, oh, hypomania really isn't a thing. It's
Mm-hmm.
you're either manic or you're not
Mm-hmm.
manic. And like,
Mm-hmm.
I think when you were saying it before, that like mania is very obvious, right? People,
Yes.
when you see a mania or manic episode, boom, it hits you right
Yeah.
in the face. This is what it is. And boom, the diagnosis is made.
Right.
And bipolar 2 hypomania begets this cyclothymia. Again, these kind of like not quite manic episodes get kind of this rep of like, it's not really a thing. It's just someone's
Mm-hmm.
just like a little bit happy or really happy and blah, 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 blah,
Mm-hmm.
blah. And it's like, it's not quite there, right? It's definitely, there's something that's popping up there that raises some alarms here and there.
Yeah.
And then I think kind of also like what to your point, when again, what we were alluding to before, like the 20 meds in 3 years is a lot, right? It's the big aspect of that. How was that experience for you, and how was kind of like your potential like frustrations or other things that may have come along with that?
Honestly, I felt like I was a failure because
Hmm.
I had something that was common and easy to treat,
Yeah.
depression plus anxiety, right? And
Yeah.
a lot of med students experience these things. A lot of people in general experience these things. And so I was feeling like, why am I failing each treatment that's being put
Yeah.
on me? Why am I seeing just side effects and bizarre, consequences from it that like I don't know how to explain. And I felt the frustration, honestly, of my treatment team of like, why can't we get this person sorted out? Why can't we treat what's going on here? I never thought we have the wrong diagnosis until I
Yeah.
had the manic episode. And some people don't have insight when they have mania, but for me, for whatever reason, it was a controlled enough manic episode where I immediately was like, hallelujah, this is what we
This is a
have going
thing.
on.
Yeah. Yeah.
We need to get a mood stabilizer on board. But what it was for me, like honestly, those 20 different meds over 3 years, I remember coming back into clinical medicine, because I was in and out of school during
Yeah.
those years. But when I finally had the right diagnosis and the right treatments on board, not just medications, but also the behavioral treatments, which we can talk about, I
Yeah.
remember going back in and feeling so much empathy for especially psych patients, but really any patients in any context who were going through really difficult experiences. And having had my own experiences with those 20 different meds, and when somebody was on a med like that and they had a certain kind of a reaction to it, or they had withdrawal symptoms because they were being transitioned to something else, I mean, those were experiences that I had had myself and could supply some deeper level kind of empathy around those experiences for patients. And I think in the end it was a really I wouldn't say, that I'm glad I have bipolar disorder, but
Yeah.
those experiences really taught me how to walk through like really horrifically difficult things for the benefit of the patients that I had and the people in my life after that point.
Yeah. It's one of those like, wish we didn't have to go through it, but looking back on it, I got something unintended almost in a way from it, right? So Yikes. Oh, it's a process. And
Definitely.
it's yeah. How is it? So then coming back, then it's one of those things when we're coming into the world of being a doc and working as a physician and pediatrician. And one of the concerns that people have, I guess, is when we fill out, on our licensing board questions, right? There's always that question that's on our state licensing question. Have you or are you currently seeking mental health treatment, or are you taking any medications that could potentially like alter your mind or something? I forget the exact wording, but they're always along those questions,
Yes.
which is terrible, right? Because what ends up happening is it deters people from then seeking out mental health treatment, and they'll lie in it, and then they self-medicate with
Hmm.
alcohol and drugs and et cetera, et cetera, et cetera,
Hmm.
right? And this is why physicians have such high suicide rates, is because they're forced to not seek help or
Yeah.
lie about seeking help.
Right.
Talk about that a little bit, I guess, some of your aspect, and then kind of how this led into your self-disclosure as well.
Yeah, absolutely. So, to lead with some of the facts, right? We know that depression is just as one example under the mental health condition categories. Depression is super common
Yeah.
in medical trainees. So, up to 30% of medical students will either meet criteria for depression or have significant depressive symptoms, according to two recent meta analyses. But only 1 in 6 of medical students will be in treatment for their depression, right?
Yeah.
And if you think about that, like in general, most if you look at the adult population, more than 50% are who have a diagnosable mental illness are not in treatment. But the ratio for medical students is 5 out of 6 are not in treatment.
Which is
That is
huge.
wild.
Yeah.
And then you go to residency, and an additional 15% are going to be diagnosed with depression on as the median. Um, and yes, like up until fairly recently, almost every state had very punitive and paternalistic, very inquisitive language around mental health, in a way that was not on parity for physical health. Even though if you
No.
have suboptimally controlled diabetes or rheumatoid arthritis, your cognition and judgment are going to be impacted.
Yeah.
And
Yep.
but we are not applying that same level of guilty until proven otherwise
Yeah.
metric to having those conditions. And so what's happened recently, though, with the Lorna Breen Foundation having been founded in the wake of a physician by the name of Lorna Breen who died by suicide, they've formulated a toolkit to help states rewrite their licensing regulations and questions to really fit a model of parity and of encouraging people to be able to seek the treatment that they deserve. And about 21 states, when I last looked a couple of months ago, had met criteria. So, for instance, in California,
Yeah.
we used to have a question on the licensing application which had mental health considered differently from physical health, and now it is a common question. So it says,
Yeah.
"Do you?" And it's more, and it's not phrased as categorically. It's more of like a potential impact rather than a definite impact.
Yeah.
And we'll pull up the exact language to kind of give folks a flavor of that. But what I will say is that we also, as physicians, don't have a lot of role models of
Yeah.
people who are quote unquote out with their journeys and their stories around specifically serious mental illness like schizoaffective disorder, schizophrenia, or bipolar disorder. When I was going through it, I didn't know of a single colleague who had a similar diagnosis, even though there
Yeah.
must have been tons, as many as 4.4% of the population will end up being diagnosed with bipolar 1 or 2 in their lifetimes in the US. So, we are everywhere. We just don't know that
Yeah.
we're
Yep.
everywhere because it's so stigmatized that people don't own up to it. And so, as I was going through kind of my journey and I spoke about how, I was able to figure out how to stay well 2015 onwards, part of my own recovery process was dissolving my own self stigma around the diagnosis and starting to feel more and more comfortable disclosing my journey with people in my life, whether it was, folks in my inner circle or beyond that, or in my professional life where, at the state level, I was working on an initiative called ESA's Aware, where we were really helping to rethink the way the medical system deals with impacts of childhood trauma, right? And it
Yeah.
felt very relevant to disclose sort of where I was coming from in those policy conversations. And I started telling more and more people, and it felt to me like, as I was getting a better and better handle on who I was with the diagnosis and apart from the diagnosis, that it was a key piece of who, I was becoming and who I had been. And also, I wanted to do my part to start to dissolve the public stigma that there really exists around this diagnosis,
Yeah.
and to say, while I was in the position of acting California Surgeon General, that hey, you can walk through a really, really, really complicated and difficult period of your life and really struggle from a mental health perspective, and then still figure out how to build a life that you want in terms of sort of your career goals and your professional and personal ambitions, and be a parent and be a partner who is loving and supportive, and just really start to kind of dissolve the parts of the stereotypes that are out there associated with bipolar disorder. Again, knowing that I'm not the only person with this story, but to
Yeah.
do my small part to start to combat some of the stigma and the shame that exists around it.
Yeah. It's important because, again, like you're saying, is you need to know that people are out there that are succeeding, because being a physician is tough. Being somebody with bipolar disorder can be tough, but these things, are not mutually exclusive. Like, they're not going to like keep you from doing what you're doing. I mean, before you were kind of mentioning that it maybe have prevented you from kind of maybe necessarily going into neurology.
Yeah.
But at the same time, like, there's kind of that aspect of learning our limitations. I know I've had some patients who were medical students as well who've been diagnosed with bipolar disorder. And, we have a similar conversation to kind of what you're describing, where I'm just like, you understand that this is part of this is part of the journey, right? This is part of what the medical student journey is like 24 plus hour calls and like doing night shift for a while. Is that going to be compatible with, with this diagnosis? And how do we go around this? How do we kind of come up with accommodations or disclosure of this kind of things to the school, residency program, etc., so that we can stay as healthy as possible? And like, I think this one person, not to kind of get too much, not to violate any hippos or anything like
Sure.
that, but
Yeah.
like they had wanted to do, again, like a intense kind of um, intense surgical training, which would have involved, similar to what you're describing, like being on call for like a week at a time or two. And like, it just wouldn't have been compatible with that lifestyle if they wanted to stay healthy as possible. So I was like, we have to really reconsider some of these things, right?
Yeah. And it's not that you can't do the things that you really want to do in your life,
Mm-hmm.
right? If I,
Yeah.
I mean, as long as you are protecting your sleep, you can do just about anything you put your mind to.
Yeah.
And I think that's also important for people to know, and to internalize. Sometimes you get this diagnosis and you feel like, oh, life's over. All the
No,
things I thought I was going to achieve in my life, like let's take them off the shelf.
no.
But you can actually do a lot once you figure out how to manage this disorder. Just like any chronic health condition, it doesn't have to get in your way beyond the kind of being really super careful around the circadian shifts.
Yeah. Which is the key, right? It's one of the reasons, like, whenever I'm talking with any patients, I always ask about the sleep, and they're always like, why are you asking about my sleep? I was like, because it matters. It
Yeah.
matters in everything, and everything. It impacts all the stuff that's there.
Right. I remember actually on my psychiatry rotation in medical school, one of my attendings said, sleep in psychiatry is like a fever is,
Yeah.
to an ID doctor. It
Yep.
is the first thing to sort of flare and let us know there's something wrong. And then we have to figure out what that is.
Yeah. Talk also about, like, one of the other things that we share is that we're both brown people, right? So we're both like South Asians, and then and amongst our peoples, our hemisphere, part of the world, like mental health isn't talked about, right? We
Yeah.
don't talk about it at all. Discuss that also, I guess, with some of that experiences as well.
Right. You know, when I shared my journey publicly, as we had been speaking about, one of the ways I did it was in the LA Times. I wrote an op-ed, and I got, I would say, an avalanche of responses from a lot of different kinds of people, but a big segment were South Asians, in the diaspora as well as in South Asia,
Yeah.
saying, hey, we need to talk about this more. And here's my secret story, or my family member's secret shameful story that, has never been told. And of course, as a brown person, I'm going to connect with and inspire people to share what they've been going through, because it's a similar community. But I will say, like, the stigma is deep and very strong in our community,
Yeah.
regardless of sort of where you find yourself in the diaspora. For instance, I think it was only after I shared my story publicly that, my parents have had conversations with their acquaintances around what this was like. Or I'll tell you, like, some of my in-laws cautioned me not to share my story because of what it might mean and
Hmm.
what it would, and what it might lead to from a professional standing.
Yeah.
It, it's just remarkable. And I think we have to put ourselves out there, and we have to have these conversations for that stigma that's so deep in our community to start to feel a little bit lessened.
And it's amongst South Asians, like we joke that we're like the gossip. Our culture is gossip, right? And backbiting and everything like that. That is the South Asian culture, is talking shit about everybody. But there's that aspect where like even the stigma within mental health. So there's like the stigma within mental health in America, which is
Mhm.
like pretty bad in itself. But then like it's so much worse, I feel like, amongst South Asians and everything that comes along with that, and it affects things like when we're doing family histories, right? You're
Yeah,
discussing like, hey, nobody in my family history had anything like this. You may have, but nobody talked about it, right? And similar, like in my family, anybody else's family, is like these things are there, but nobody talks about it, or they just get tucked away in the
totally.
corner. Or like we're like, oh, we don't talk about uncle, that uncle over there. Like we
Right,
don't know what happened with them, just something, right?
right, right.
So, which is trouble because,
Yeah,
it affects planning for future and our own kind of health histories and what's going on with ourselves. So, potential
yeah,
things. So,
yeah, absolutely.
with this too, like, I mean, you had talked about being a parent with bipolar, being a new mom, right? Or a couple of years at least now,
Yeah.
right? And I just had my baby number 4, and with like now
Wow.
she's 6 months, 6+ months old now. So it's like,
Congratulations.
thank you, thank you. So it was like one of those things where I was like, oh, we forgot about the sleep. We forgot about the fact that like
Right,
everything
right.
gets destroyed. What
Yeah.
is that like? And then kind of the discussion around that.
Yeah, I'm so glad you asked about that because, I think with bipolar in specific, you often get the message that you can't stay on your meds. You can't make it through a pregnancy and a postpartum period without falling ill again. And I was definitely very terrified.
Yeah.
The two keys were staying on the regimen that we had figured out was going to be safe through the pregnancy, which for me was the same as the regimen I was on for, the rest for several years before my pregnancy.
Yeah.
Number two was sleep protection, right? And so for that reason, I made the decision not to breastfeed at all, which meant that the second I gave birth, I could start to sleep 8-hour nights. And that was really essential for staving off a postpartum episode.
Yeah.
And we also made it a priority to set aside funds and hire a postpartum doula, like a nighttime person whose
Yeah.
responsibility would be to stay up with our baby and feed him and get him back down. so that I wasn't, overburdening the other people in our unit, right? So my
Yeah.
mom came and spent 2 months with us, and then my husband as well. But after our son was sleeping through the night, we had the concerted, conversation and decision that Ashish, my husband, would be sort of the night on call person. So anytime Rumi, our son, gets sick and needs extra attention at night, Ashish is on call. He does the mornings as well. I put Rumi down at night so that Ashish can usually fall asleep earlier to be
Yeah.
able to be available at the times that he's needed. But we figured out a way to really make sure that both of us are getting enough sleep around you know, not just postpartum, but really like early parenthood, which is such a crucial time in everybody's life.
Yeah. Yeah. Yeah, it's massive just because I think, you need to have that support system, right? I think you're kind of mentioning having the support system in there because a lot of times, when we have people who are going through pregnancy, having a baby, and bipolar disorder that's there, and they're like, "Well, what do I do? Do I need to just again?" There's so much just kind of misinformation and myths out there about like you need to stop all of your medications, and there's
Right.
so many times in training that we would have a pregnant individual come through and they're manic, floridly manic, or psychotic, or something or other, or depressed, terribly
Yeah.
depressed. And
Yeah.
it's because, again, somebody told them, a family member told them, a friend done here and there. So they read on Facebook that they need to be off the medications.
Right.
And you get these terrible outcomes. And you're like, no, like the medications can be safe. You just have to be aware and just watch out for stuff. And for the most, overwhelming majority of the times, like nothing will happen, nothing terrible will
Right.
happen.
Right.
But it's just kind of having the team there, right? That support system, which is so, so important. Well, let's do one last question. Let's talk about kind of the difference. I know we talked about stigmas and diagnoses. I know I've been very open about the fact that like I have ADHD and
Mhm.
that's like an okay, it's a cool, trendy thing to do. Bipolar disorder is not always kind of seen the same way. So
Yeah.
talk about that like just a little bit about like how maybe your self-disclosure is not quote unquote as cool as other people's, right?
Yeah. I think more of the people that I know with ADHD are open about it than the people that I now
Yeah.
know who have bipolar disorder. Most of them are closeted. And that's not for,
Yeah.
no reason, right? There are deeply stigmatizing beliefs that people hold about those of us with bipolar disorder. And so coming out and saying, hey, I have this condition, can be a little bit harder when that's the case. At the same time, the only way stereotypes shift is when you see enough examples of folks that you think maybe don't conform to those stereotypes who have the diagnosis. And then you build sort of a more three-dimensional view of what that condition can look like. And we know just, from the literature that the only thing that dissolves stigma on the grand scale is meaningful contact between those who do have lived experience and those who don't, right? So that people can start to understand the nuance and context around different people's stories. And so, yes, it's in some ways sort of more scary and less so-called cool to share a story around a stigmatized condition, but I think that it is in some ways more needed and more meaningful to do so as well. And the number of people that said, I've never met somebody with this diagnosis in my walk of life, specifically within the medical community and the public health community, were not insignificant. And so I'm really thankful that I
Yeah.
was able to do it.
Cool. Last quick question. What
Mhm.
is your self-care? Because which we
Yeah.
know is always so, so important.
I do a lot of things. Number one, of course, is guarding my sleep. So in the evenings, I put on amber glasses, which, block blue light, which are the wavelength of light that wake the brain up and make you think it's daytime. And so that's really helpful. I mean, that's one thing I do. I have a very sort of usually try to go to bed at a reasonable hour every day. I protect my sleep in the ways we talked about around the baby being tended to by my husband overnight and in the early morning. And then, exercise is key. I like to get in at least 45 minutes to an hour's walk several times a week. I spend time being mindful. I spend time connecting with the people in my life who are important to me. I spend a lot of time actually decompressing and resting and having downtime, especially because my professional weeks can be pretty go, go, go. There's a lot of self disclosure, there's a lot of speaking, there's a lot of sort of high intensity, energetically costly types of activities. And so I spend a lot of time also thinking intentionally about blocking time for decompressing and rest and recuperation. So all of that together sort of gives me the day-to-day stability that I need.
Awesome. Good, good, good. Well, I know that we got to wrap up, but how can people follow along with your journey? Any plugs that you
Absolutely.
have?
So the best way is I have a weekly newsletter which really focuses on well-being insights, which is askdrdevikaB.substack.com. I also have a monthly podcast and YouTube channel experience around sharing stories of mental illness, which is called Spread the Light with Dr. Devika B. And we can share some of the links to both the podcast version and the YouTube
Yep.
channel with you all. But I would say those are the two best ways to do it. It's been a pleasure to be here with you, and I really appreciate your giving me such a wonderful set of questions and having me on here.
Yeah, no, it's my honor, and again, I appreciate what you're doing. You're so valuable out there in the field, and so keep doing what you're doing, and we
Thank you.
appreciate you.
Same to you. Thank you
Cool.
for everything that you do.